Recording in progress.
Okay, let's talk about the innervation of the heart by the autonomic nervous system. Remember, there's going to be dual innervation, so we're going to be talking about the sympathetic nervous system and the parasympathetic nervous system. But those are motor branches. Those are sending information out to our organs. The heart also has sensory information leaving the heart and going to the medulla. And so up here we see these sensory nerve fibers. In the blood pressure chapter, we'll talk about our baroreceptors and our chemoreceptors and how they detect. Baroreceptors are going to detect high blood pressure or low blood pressure. Chemoreceptors, the amount of, say, carbon dioxide or hydrogen ions. And that information will travel along sensory neurons. Notice we have sensory neurons here, unipolar. And they're going to be going to the cardiac center in the medulla. So the medulla is where our cardiac center is. And really there's going to be we can separate it into a cardio acceleratory, that's ECCEL. I wish I wouldn't have said that I was going to spell it, or, and a cardio inhibitory center. Cardio inhibitory. So when it comes to the cardio acceleratory, that says acceleratory, we're going to have the sympathetic fibers issuing out to the heart. When it comes to the cardiac inhibitory center, we're going to have the parasympathetic fibers, because the sympathetic are going to speed up the heart rate, parasympathetic are going to slow it down. So we do have sensation going from the heart to the center, so we can respond, either speed up or slow down. When it comes to blood pressure, we don't understand that yet because we've not gone over it, but we'll see how cardiac output and blood pressure are going to be tied together. Now, if we just look at heart rate and the heart, we have, if we're issuing from the cardio inhibitory center is the vagus nerve, part of the vagus nerve. We have this parasympathetic fibers coming out, going to, look at this, the SA node, sinoatrial node, which is the pacemaker of the heart, and it's saying slow down. The sympathetic fibers are also coming out, and they're coming in and they're saying speed up. And so we have this dual innervation, and whichever system wins depends on your actual state of being. Are you in a fight or flight mode? Are you exercising? Then the sympathetic fibers are going to speed up your heart rate. Whereas if you're in rest and digest mode, the cardiac inhibitory center is going to win, and the parasympathetic fibers will send more action potentials per unit time to that SA node and slow the heart rate down. Here we also have an interesting little image of the sympathetic nervous system coming out, because remember, in the adrenal medulla from the endocrine chapter, it contains the catecholamines, epinephrine and norepinephrine. And if we zap with this nervous fiber here, with this little axon coming out here, if we zap those chromatin cells of the adrenal medulla, then they release epinephrine and norepinephrine, which will go through the blood, and that will affect cardiac output by increasing heart rate and also increasing cardiac contraction, the force of contraction. Okay, so this is everything that we just said with a few extra stuff in there. We do have extrinsic control by the nervous system, and we also have hormonal influence, and ionic imbalances can affect heart rate as well. So here, if we just think of this, how we're controlling heart rate, not contractility. If we move right into this next slide, which is discussing heart rate, you should know what increases your heart rate and which lowers it. Under normal situations, because these parasympathetic fibers run along the vagus nerve, if the parasympathetic nervous system is in control of this SA node, we say you have a vagal tone. So normally the heart is under vagal tone, but under fight or flight situations, then the sympathetic nervous system takes over and your heart rate increases. Anything that increases, any factor that increases your heart rate is called positive chronotropic agent. Chrono, this is to act upon. Chrono is time. So think of that for heart rate. Anything that slows down heart rate, so your parasympathetic fiber, would be considered negative chronotropic agents. So what are some other things that affect heart rate? Age does. A little fetus has a super fast heart rate, and our heart rate declines with age. Females usually have a faster heart rate than males, so gender actually affects heart rate. Now, on your final exam, I'm going to be asking what affects cardiac output, not what is affecting these things. I don't want you to add into the cardiac output situation, because a cardiac output, when we're thinking about cardiac output and how it depends on heart rate, we're thinking about a moment by moment situation. These are not moment by moment situations for the most part. The lower your fitness level, the higher your heart rate will be, or vice versa, we should say, the more you work out, the lower your heart rate is, because your heart is a muscle and it has more, it can contract more efficiently if it has been worked out with cardio. The higher your body temperature, if you'll notice, if you get a temperature, your heart rate goes up big time. And the term for a high heart rate over 100 beats per minute is tachycardia, and a low heart rate is bradycardia. Tachycardia, we run into the problem of not being able to have enough end diastolic volume for our stroke volume, because if the heart's contracting too fast, we don't have time for it to fill up and have an adequate stroke volume. So tachycardia, much higher tachycardia than 100 beats per minute, can really reduce your cardiac output by reducing preload and end diastolic volume. And likewise, you would think, well, bradycardia, then you have enough time to fill, increase preload, and then you can increase your cardiac output by increasing stroke volume. Well, the problem with bradycardia is that that would be true if you're fit. If you just have a really slow heart rate, maybe because you're in junctional rhythm, you might not have a fast enough heart rate to get blood around your body, and then you would be symptomatic. And if you're not getting enough blood to your brain, you'll be dizzy, disoriented, etc. Okay, so that's heart rate. This is going to be the shortest lecture ever. The biggest homeostatic imbalance to know about the heart would be congestive heart failure. And we're going to have myocardial infarction, by the way, that is a heart attack. And if you remember back in those lectures, in the myocardial infarction, this has to do with the coronary blood vessels. If you're in my class and you've gotten so far, and you can't immediately understand what the coronary vessels are, start over. So myocardial infarction, if you have a blockage in the coronary vessels, and then you have a heart attack and the heart muscle itself dies. On the term congestive heart failure, cardiac output is so low that the body can't get enough blood to it. And it's caused by a variety of reasons, and they're not often known. It can be brought on by coronary atherosclerosis. So you need to know, what is coronary? Coronary are those blood vessels. If there's hardening in those blood vessels and it really affects the heart over time, then it can cause cardiac output to decrease. If you have persistent high blood pressure, remember this is that afterload concept. If you have persistent high blood pressure, then the heart has to work harder and harder and harder, so it's easier to wear it out. If you have many heart attacks, that can lead to congestive heart failure. Basically, your heart is just not working to get the tissues the blood that it needs. And in multiple heart attacks, remember that those cardiac myocytes, when they die, they're not replaced with more cardiac myocytes through mitosis, they're replaced with scar tissue. And there's something called dilated cardiomyopathy, and oftentimes it's unknown why someone has dilated cardiomyopathy, but the heart gets bigger, but the walls are really flimsy. They're not as strong walls. It's not a built up big heart because you're exercising, but rather just a stretched out sort of, I hate to say, flabby heart. And oftentimes that will lead to congestive heart failure. So when it comes to congestive heart failure, usually it's going to be on one side of the heart or another. If you have pulmonary congestion, what that means is, so here we have the right side of the heart, and it's sending the blood to the lungs. I'm going to put the lungs here. Here's a lung, here's a lung, and it's coming back to the left side of the heart. The left side is sending to the body and sending back to the right side. Okay, here's the atria. So I'm sorry, I should have done the right side ascending to the lungs from this right ventricle. All right. So on the pulmonary congestion side, if the left side, here's the left side, it's pumping blood to the body. And we're supposed to pump equal volumes on both sides. So if we're supposed to pump 5 liters per minute on this side, we should be doing 5 liters per minute on this side. What happens if we're sending 5 liters of blood to the lungs, but the left side, for a variety of reasons, maybe the aortic valve was incompetent, maybe the mitral valve, issues with that. For some reason, this left side is only pumping 4 liters out. So what's happening is if the left side starts to fail, the left side fails, it's not pumping as much blood as the right side. So the right side's going gangbusters, just sending all the blood to the lungs. Well, guess what's going to happen? That's going to increase the blood pressure in the lungs. I'm having a hard day today controlling the situation. Well, you increase the blood pressure in those blood vessels in the lungs, so fluid is actually going to come out into the lungs, and fluid backs up into the lungs and is coming from the circulatory system. And so basically they have to draw the fluid off of the lungs or the person can suffocate. So the left side of the heart causes a buildup of fluid in the lungs. The right side of the heart, if it fails, so here, let me draw this again. Right side, left side, right side is going to the lungs and it's coming back here. The left side is going to the body, bing, 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 running out of space and coming back here. If the right side fails, say we're only pumping 4 liters to the lungs and 5 liters out to the body. We're supposed to be doing 5 liters on both sides. Well, what's going to happen is the fluid's going to back up into the body because the left side's going bam, 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 and sending more blood than the right side can handle. And so fluid backs up in the body, and this is what you get. This is pitting edema. Someone's pushing their finger down into this person's skin and they lift it up and you can still see the actual finger. That is oftentimes what doctors say. Do your arms and legs swell? Does something swell on your body? They're thinking about the heart oftentimes. So the right side of the heart, if it fails, you end up with what's termed peripheral, because we're on the periphery, congestion. And if it's in the lungs, it's pulmonary congestion. And that's it. You've been on the struggle bus for these lectures. Hope you have a great day.